So go ahead, John.
Whoa.
Whoa.
Good evening, everybody. Good to see you. Or night, I guess. Introducing David is difficult because he has one of those CVs that you don't read your way. And so I'm going to give the grotesquely short version.
Indeed.
He was on the National of Mental Health for 20 years, where he ran the Experimental Therapeutics Branch. In other words, his job was finding new therapeutic ways of treating psychiatric disorders. His particular interest was the hardest of all of schizophrenia, and he has continued working on that since he was hardly retired. And he is in his field absurdly distinguished. My family has a particular reason, however, for knowing David and for valuing it, because our son is schizophrenic, Oliver. He's schizophrenic. He was at age 22, he was studying in Cairo in Egypt, and one night he began to hear his friends talking about it in his head. It went downhill. And after some travels, we found David. And David managed amazingly to give Oliver more than a decade of normal life. Personally. And for that we've been eternally grateful. Even then, however, it couldn't work forever. And finally, the best therapeutics and the best counseling didn't work, and now we've lost Oliver. So, leaving aside that family tragedy, one thing we learned in the course of this, because we made a decision we wouldn't keep Oliver's ailment secret, we wouldn't broadcast it, but we talk about family, we say, well, it's schizophrenic. What we found was an amazing number of people, among them many in this community, who once we raised it said, well, of course, like my cousin, my brother, my whatever, we realized that the incidence of mental illness of varying degrees of severity is much more widely spread than most people realize. And so I'm glad to see this turn out today. It doesn't mean all of you have either personal or relational problems, but it does mean that David is speaking to an audience that wants to hear what he has to say. So with that, David.
That was such a sweet introduction. When I met John, he told me that he worked for the Sunday Times, which I had never heard of. I mean, that sort of thing. And there was this, I was in London at the end of college, and I had this, it was a date. That was my wife telling me to show up. And we were going to go to Eastbourne to see the tennis tournament. And it was right after the 7-day war, the 6-day war, what was it? Six-day war. Thank you. And an insert from the Sunday Times went through hour by hour of that war, and I wrote it with this girl was it too. I read it to her. But we went down, and it was from the Sunday Times, which I'd never heard of as a separate newspaper. I asked John where he worked, and he said the Sunday Times, and he explained to me that that's a separate entity, correct, as a newspaper. And then I told him the story, and he said I wrote it. How do you like that one? Never forgot that moment. That was something. And thanks all for being here. And I'm not just here to tell you about the person next to you is a little screwy. Okay, you guys already know that. I think I entitled it "Psychiatry Through My Eyes," which is better than other parts of the body, I suppose. But there's going to be a few minutes. I got to tell you how I got here. Not so much here, but here into psychiatry, and John's going to keep after me because I want plenty of time for questions. And I'm going to talk about schizophrenia because I spend a lot of time psychiatry in general and the modern psychiatry and psychedelics. And then I'm going to hand out psychedelics and John is going to dance for us. It was an unusual meeting, but John was asking for that. When I went to a medical school interview at a very fancy place, I wasn't in college in a fancy place. I was a college where I knew a guy. Understand? You know a guy? Yeah, okay. I was in Jersey, okay? I knew a guy. Then I went to this very fancy medical school and everybody had straight hair and all sorts of shit. I had to straighten my hair for the interview and everything. And this little anatomy professor, of course, with flippy straight hair, and a picture of an old New England church behind. Oh, what am I doing here? Said to me, "What kind of doctor would you like to be?" And I said to him, I guess like many people you see, I think I want to be a psychiatrist. Silence. And he said, I forget. I've never met anybody who wanted to be a psychiatrist. How would you like that for your interview? And my hair started to curl. It was a big problem, but it was a very special place for me personally, and led to my whole career. There were two movies I saw as a kid, and John, not let me ramble on, because your questions I got a lot to do, okay?
Brown is what you got.
Yeah, you okay.
If the audience starts, if the audience starts booing, you know.
Okay, okay.
John, I must send you a signal.
Yeah. I think they're turning on me, not to be paranoid, Troy, but I think they're turning on me. There were two movies I saw. I don't know if anybody's old enough to remember the movie David and Lisa. Does that mean anything to anybody? And Howard De Silva played the sweetest, the nicest shrink he could possibly be. And I remember seeing him in this movie thinking, boy, that wouldn't be bad. Did you know Howard De Silva? He was a guy who was communist branded, and he was a famous actor, and blah, blah, blah. But sweet man, and he was the shrink in that particular story. And I remember thinking, boy, and it's such a different personality than me. That was nice. And then I saw another shrink where Rod Steiger was the shrink, and I related to him better. He was yelling at the patients and shit like that. But in all honesty, it was movies. My dad, who was a doc, was very nice and very open to things. And he said I could be any kind of internist I wanted. So I could be a cardiologist. He wasn't going to. I had total freedom within internal medicine. But he understood when I declared that I was going to become a psychiatrist. And I had an opportunity to stay where I was, which is in New Haven, to do a psychiatric residency. And I had great time. I never put on the outfit of any sort, but I got through. And it was truly a great residency, and one that I appreciated. And that's where I began to do science. And they required a thesis at Yale Medical School, which is unusual. That was my first opportunity to do science and publish papers and stuff like that. And I owe it a tremendous amount. Comment. I'm 70. I'm going to be 77. So I've been a doctor for 53 years. I hear like them apples. Yeah, even that guy Ruth did a little bit. Yeah, she went, "Whoa, come on, Ruth." Yeah. The world was changing when I became a psychiatrist. So we were in the transition from psychoanalysis, total psychological therapy, and particularly one with a high theory situation, which was the dominant thing. And Yale was very famous in it, into a time when science and the brain and modern psychiatry was taking place. And that was fun to be part of that timing. There was science coming. We thought very big at the time, but I still live in a community where a lot of my professors would say, "Dave," they're the analysts, that's what they say, "Dave, you're dealing with a very sick patient." And I said, "Well, I'm sick. This patient's crazy." It took me a long time to communicate to the psychoanalyst. But we were the generation that was in transition to what you probably know as psychiatry today, medications and so forth and so on. And the history of psychiatric medications and the pharmacology is something I spent a lot of my life doing, and I find it interesting, but it really changed the game. Freud invented a language we still use. Great analysts still, to this day in seeing patients, the things that you learn and so forth, I still enjoy. And I know the most important thing with the patient is connecting. And there was an analyst who was the father of a student of mine at Yale who made the statement that psychotherapy was a restoration of morale. I always liked that one. And it was a nice summary across all different ways of looking at it. But my thing was going to be, I did a year of internal medicine, so I found my wife. That's how I got Kathy. I would have never found her in psychiatry. I had to go to internal medicine. And then came back outside New Haven, then came back to New Haven, and did it all there. Now, I'm almost important. No, I'm just talking. Vietnam. Vietnam is the reason I'm here. I thought this was Vietnam. I was so confused when I went down Wisconsin. I expected food and no. The draft was on when I was in medical school, big time. And there was something, I think docs here, it was called the Berry Plan, where you get deferred and you go into the military for 2 years, usually right after your internship. And so they were plucking guys and gals out before they even did their training. It was an interesting time, with one exception. There was one place where I could get deferred from the war, which is good for the Jews, right? We like that, right? And it was interesting. And I became a commissioned officer of the United States Public Health Service. And that is one of the armed services. We wore Navy uniforms with a different insignia. I never really wore it at work, train those, but I wore it at home after a shower. Mostly just the hat and cocked to the side. So I spent a career as a commissioner. He's saying, maybe I will speak up. So I spent a career as a commissioned officer. And that was the fundamental personnel system for NIH, as well as the CDC, which you hear about these days, as well as the Indian Service. And prison service, and it was an interesting group. It's the second oldest part of the armed services. It was developed with the Marines, and Marines were on boats, as you might imagine, hence the name. And the doctors for them were officers from the United States Public Health Service, and it goes way back. So that's how I ended up here. I had no idea planning to come to Washington, and I go to NIH. Now I'm transitioning. Can I transition, John?
You can.
Okay, so I'm looking for instructions. Transition to NIH. So coming up here was something that was really difficult compared to where we were. And I came up with Kathy, my lovely wife, and my mother, looking for a place to live. And the lowest moment, I think, of our transition is a guy pulled up with a motorcycle in Georgetown, and on his license plate had MD, Maryland. To my mother, it meant he was a doctor. His dad always had an MD on his plate. And he goes up to this kid getting off the motorcycle. She says, "Where do all the doctors live?" Kathy was suicidal. We made the transition here, and it's been home, and it's been terrific ever since. Number two, going from being chief resident in a hot shit in a big place, and then coming here to the wasteland of the NIH was not the easiest thing in the world. And you've seen the big brick shit house there on campus, and walking in there. And then there was a medical student. Oh, I was doing medical, and I used to be in charge of everything, but a medical student who knew everything, where to go, I had no idea. Okay. And he saw me pissing in a corner, and he's a nice kid. And he said, no, here's the bathroom. And that medical student, it was Trey right there. Trey Sutherland. There he is, right there. Yeah. Who came back after his residency and came back to the NIH and had a great career studying dementia and Alzheimer's disease, and is also here, a resident in Somerset. So I somehow made it through that initial transition, okay? And then you wait for opportunities, you push people. It's like playing football. It was very competitive. Many people were smarter than you, but they didn't necessarily do as well as you did. Capiche? You know what I mean? That guy who could run real well, who wasn't a great player. Yeah, there was a lot of that, okay? And you had to look after yourself. That kind of fit my personality a little bit, and I survived. And they first started me studying something that was just invented, so I thought it was really cool, and that was called the endorphins. Had just been discovered. So I had a boss who pulled me out of where I was, gave me a permanent position, and gave me half a secretary, half a research assistant, and Dieter, who's a 6'7" German fellow from NATO. And he and I worked on endorphins, and we had learned about science. Also, it really was a very productive career. I don't think endorphins turned out to change the world, but that's how it was very exciting in the day. Okay, and this is to bring on one. We did a World Health Organization collaborative study with naloxone, opiate antagonists, and schizophrenia. It was run by a Russian. And he looked at me with the goldest teeth I had ever seen in the world. And it's like, you are so edible. I mean, he just this was during the height of the communist period. And once we were meeting in Geneva, and I saw him come back. I said, "What do you got, man?" Oh, he bought a silk shirt. That was Russia when it was really Russia. But I moved on, and I had an opportunity to take over the schizophrenia research wing. And that's what I did. And you do things off to the side related to the brain and aspects of that. But schizophrenia became sort of what I did. And as an intern, I always liked critical care. I liked taking care of sick patients. I liked being relevant. And that turned out to be a very good space for me, and one that I enjoyed in parentheses, because John said it, and his boy was one of the sweetest. And one of the nicest days I have had as a professor was at his wedding. Remember? You don't forget, how could you forget it? And Oliver, anyway, that's another whole conversation. And John brought it up, I would never have. But that was a heartbreak. And I get a lot of pleasure and joy in what I do, and there's a lot of sadness. And you lose people. And sometimes you lose them after they're out of your care, but you sort of know them and they're in your world somehow. And they die. And dying is a bad outcome even for surgeons. Okay? You know what I'm saying? It's bad. And so it's a tough business. Now, let me tell you, can I talk a little about schizophrenia and also interrupt however you do questions here, John. You know, what do they do in Parliament? Don't they yell at you in Parliament?
Questions later, but finish.
Oh, so I just speak. I saw the crowd.
You've got a good crowd.
There we go. Okay, schizophrenia. Holy smoke! What an illness. I am not the scientist. I don't do science as I did at one time, although I have my hand in all sorts of aspects to it. But the illness I think about every day, and literally every day. Maybe because there's all sorts of stuff in my way that says it and does it because it's all there. But it's the illness, and it baffles me to this day. And it's the most severe of the mental illnesses. It is often, but not always, tragic. And it has been around for a very long time. And I'm not telling you about any biblical characters who may have had the illness. If you forced me, I'd say one or two, but I'm not going to do that. But it's been around forever. A couple of things about the illness. And you guys may know, illnesses are not the same frequency or the same commonness around the world. And so stomach cancer is big in Japan, I guess, because they eat, cold fish and stuff like that, much bigger than here. Other places have genes. HIV did not go up to Scandinavia very well. And they have a little different gene marker. So they're not, schizophrenia occurs at almost the same, as best you can tell, the same prevalence everywhere in the bloody world, across all sorts of cultures. That's unbelievable. It's something. And you know, in the United States, because many of the folks who have the illness are on your streets. And it used to be you just only saw that in San Francisco, but I think you can go to any major city and you see it. And one of the aspects of schizophrenia, I'm going to say I enjoyed in quotes, what was certainly different than other parts of medicine, is you're dealing with an illness that involves behavior and obviously the person's well-being and the family and so forth and so on. But it also involves society. I never had so much dealing with the police in my life. I've never been so close to being killed as I have seeing patients with the abuse. A colleague of mine was killed by a patient. It can be a very dangerous thing, doesn't have to be, but it can be. And commitments and treating people against their will, not a traditionally American thing, but is a fundamental part of schizophrenia. When I first went to my first American Psychiatric Association meeting as a resident, there was a demonstration of people for getting our people onto antipsychotic drugs. Then there was another demonstration at the same meeting saying, no, don't you dare put anybody on it. That's psychiatry. And that was my psychiatry in transition of periods from that to this. And I remember as a resident, I'm going, oh, it was peculiar. But then when you get into the NIH, we saw it in one way is to try and figure it out as best you could. Now, what illness is it? John just gave you a very personal statement, and I appreciate it. John, I really do. And Oliver was the sweetest. I think of him all. I can only imagine how often you think of him, but I do often. I was just looking at the interview I had with him that I had. It's a fascinating disease, but it's a disease. I'm getting another piece that I think about every day. You think I'm forgetting what I say every day. Age of onset. Oh fuck! Pardon me. Sorry, Kath. She's here to make sure I don't do too much Jersey stuff. You know what I'm saying? You understand? I know a guy. That's my Jersey side. Okay. Fuck, this illness starts in one of the healthiest periods of your life, between age 15 and 25. Like clockwork. And so after all the 23 years in science, and I was with the FDA, I was on their advisory committee. They were a bit of a stiff group, but I learned an awful lot. I developed drugs, worked on all different kind of things. But when I opened my doors to see more patients, I saw a lot of patients with schizophrenia. I don't know another private doc who sees patients with schizophrenia. I'm sure there are some, but not many. It's very few. No one sees these people. And you say, you go to the services that the community gives, they're terrible. Not terrible, it's not fair, but they're very inadequate. And that's why so many of these folks are on the street. But the onset, diseases have onset. So cardiac disease, historically, my dad's generation was a disease of late middle age. Every doctor my dad had cardiac disease. All his buddy doctors had cardiac disease. Age of onset. Testicular cancer. No age of onset there, guys? Very early. It's one of the few, it's the time of life you get schizophrenia. One of the few bad diseases you're open to is testicular cancer. Teenage, 19, age 20, that got a little older. One of the big bikers had it. What's his name? Yes. Yeah, in his 20s. This is an illness, starts in the late adolescence, early adulthood, and extends a lifetime. And why is it starting? What is the mechanism? What's turning on the gene or not the gene? This is the kind of thing your son is going to figure out. And I'll come back to genes, and not the ones you wear, but the ones that I'll talk about genes actually. I had a pair. Anyway, okay. Yeah, and I think about it. And when I see somebody come in with their son or their daughter, if this is too grim, stop me, okay? Because I can be a shtick like nobody. Okay. When somebody comes in with their son or daughter who's having a hard time, is in that age group, I almost have a little PTSD in my old age of just, am I seeing the beginning of this goddamn thing? Because if so, I know what the family's in for. And it's just part of the business. I'm not sure other shrinks do that, but I think about it, and I think about it all the time. And we don't know why it starts at that age. And well, people have a lot of theories, and I've been around bullshitters beyond your wildest. And we did science with good data and all those good things, but those questions are fundamentally unanswered. Is it an inherited disease? Okay, the first time that sort of came to mind was when I was beginning to study it. And there were studies out of Britain, in Lancet studies, and there were twins. So if you have a sibling who has the illness, the chances of you having it is about 10%. If you have nobody who has schizophrenia, then you're like the rest of the population, about 1% of the population has it, which you may think is rare, but that makes it a common disorder, 1% of the population. Okay. So these studies were twins, and the Brits have you guys have all the records on things. And they would take identical twins. The one who had schizophrenia, what was the concordance? That means what did the other guy get it to? 90%. People were blown away. If you're a fraternal twin, which means you're coming from two separate eggs, a separate genome yourself, it's about 10%, which is about the frequency of any sibling. And if you have no sibling or any other first degree relative, it falls into that 1% category. So the first notion of thinking of it as genetics certainly was that, when we first saw that. I'm going to come around to the genetics because it's been a hoped for savior. It's been enormous pieces of science, and it's been, in my mind, The Big Short. Remember the book, Big Short? I just want to bring it up in case people want to talk about money. Okay. They thought it was going to change the world. Capiche? The way those guys in The Big Short, the way the one guy who stood up and said, I don't think you got this right. It looks to me this is going to fail. Oh, they yelled at him. That's the way I felt with aspects of the genomics of schizophrenia. It's been one of the more difficult, unproductive things that has taken over much of schizophrenia clinical work and other work. And we've never quite come to full grasp of that. But it's interesting, and you will hear more about it. Now, illness. What is illness? Fundamental element is psychosis. Everybody know the word psychosis? Anybody had a bad day and thought they were on Mars or anything like that? Psychosis is loss of touch with reality. If I think I am the mayor of Somerset, be careful, dude. I'm getting sicker by the day. Okay, that's not a bizarre delusion, but it's a delusion. It's not true. It's possible theoretically. But a lot of the delusions for schizophrenia, the way we used to talk about, are what we call bizarre delusions. So if you think that there's a man from Mars, do I believe that person's thoughts are in my brain? Things like that, at least as far as we know, cannot happen. That's characteristic of delusions of patients with schizophrenia. And the paranoia often goes with that, and it's an extraordinary life these people have. They have The split personality, I don't know where that term came from, other than that they're living in a delusional world in their head. And yet they sort of have to function in another world to varying degrees. But there's no particularly split personality. That's a whole different story. But the paranoia that goes on with it is something. Now, families. My heart. Hi, my dear. Dana's son is ripping it up at AU. And he had some hard time and he's doing just beautifully, which is good for everybody, all the way around. The families. Now, to see your kid hurt, come on, any of us, anybody, is the worst. I have a little, it's a neurotic thing, and in case you hadn't noticed, John, I'm very neurotic. Okay, I just wanted to own up to it, okay? You hear me? You okay? John? Okay. The British accent has always, really put me in my place. Tough illness for the family. But sometimes, in my judgment, oftentimes, the undersung heroes are siblings who are well. And life is tough enough. And to have a sibling who's ill breaks your heart because you love them. But then not only that, what it does to a family. There's just so much oxygen in the room. And the amount of work families have to do to help the son or daughter who's ill is extraordinary. And there's not a sibling I know who hasn't at some time felt pissed off that he or she was getting cheated. And that's not a rough word. But, couldn't get the attention from mom or dad or the family that they want and need. And yet they feel guilty the moment they say it. So I always give them opportunity to say it to me. And to tell them I don't blame you. And it's a tough one, and I'm with you on that. And here's what we're gonna do for your brother. He says blah, blah, blah. But just to give them, no one gives them that opportunity to say that. The psychoanalysts, they can give anybody an opportunity for anything. But all kidding aside, I care about the siblings a great deal, as well as concern about do they get sick, or their kid's gonna get sick. It goes on and on. And they're the heroes. People like me, we're not gonna be around that long. Who's gonna take care of the brother or the sister? Your sisters, Oliver's sisters, and so forth and so on. So I try and do that as much as I can, not always successful, but they try. So the illness is characterized by delusions, which are false beliefs. And then it's characterized by hallucinations. An hallucination is a sensory perception that's not there. For schizophrenia, the hallucinations are almost entirely auditory hallucinations. You can see some visuals, but they're not real hallucinations the way you sometimes can see in an organic brain disease. But the auditory hallucinations are what it's about. And they hear voices, which is creepy, but it becomes more dangerous and odder than creepy. So a very common working delusion of a patient who has the bloody illness is that somebody's putting thoughts in their mind. It is very difficult for them to watch television. You wouldn't, because it feels like the TV is giving them messages. I can't count the number of times I've seen it, and it's very disruptive and upsetting to them. And if they hear voices, it's from some source, not a person. It's always some source and so forth. And the voices are not benign, saying the Commanders are going to be good this year. Okay, they're usually accusatory. They usually put you down, and unfortunately, depending on the individual and the patient, they can give you orders, and orders are dangerous. And so the number of people who die, it sounds not very politic thing to say, from patients who have schizophrenia is large. And 50% of all homicides of parents are done by patients who have schizophrenia. Wow. It is a tough one. And no, they're not murderers, but they hear voices. And they think they're doing good in the world. Not everyone. Some of the delusions may be. The only way I'm going to get this world another day is if I do something here. They get these very strange, complicated delusions. And they can be large delusions themselves, being Jesus or whomever. You get that. I can't tell you the number of times that I've seen people do that. So just to mention the nature of the illness. Now, beneath this bloody illness is a person. And one of the things that I enjoy most about what I do is connecting with these people. I really do. So I ran this ward all these years at the NIH, which I did it my own special odd way. but it was a good place. But there was two very nice young women who worked where I gave jobs, whose mother was very big in the advocacy. She ran NAMI for many years. And then her sister, both of them had emotional problems. And one day, and I would always talk to them when I go around, make my rounds. You know what I mean? Hey, it's my shop. I was making rounds. You know what I'm saying? And I go around, people had to laugh at my jokes and stuff like that. And she said one of the sweetest things I've ever said. She said, it was actually her sister who said it. Both there. She said, Dr. Pickar, you make me feel like one of the popular kids. But they were troubled kids. They didn't have the illness, but they were troubled. And when I think about that, when does a patient who has this bloody illness feel popular? And that people want to speak to them and so forth and so on. And I always went out of my way. Now, patients with the illness can be very, can be fun. Oliver was great fun. He thought his dad was a spy. And that was the only delusion I reinforced. He wrote every hour of that 6-day war. Am I correct, John?
Not every hour, no.
It was done in hours, wasn't it?
It was.
It was.
I had colleagues, don't worry, I had colleagues.
Oh, you had colleagues who helped you. Okay, all right. I'm always so proud that I knew that. So that the illness starts in late adolescence, early adulthood. We used to think, sort of when I sort of got into the business a little bit, it was old from these old psychoanalytic days a little bit, that you could predict who might become ill, other than going by family history and things like that. There's something about them at age 15 or even older was telling you it's going to happen. And I was on board with that. Why not? And I went to my 15th high school reunion. I went to a small private school, shitty private school in New Jersey, okay? I went to my 15th reunion. And everybody was pretty okay, except for the number one student in our class, who was the headmaster's son, who went to Amherst, and then sort of got a fellowship to Japan. And he was mowing lawns and very ill with the disease. And the guys, the men, the boys, who I thought I knew back then they had trouble socially or whatever. So there I was just at the NIH, I thought I knew everything. Those are the guys I would have thought were going to have problems as adults. They all did fine, and they all had one thing in common. They were making more money than I was. So the idea of predicting is not as easy as you think. And autism, which at one point aspects of schizophrenia were related to autism clinically, is a really separate entity. And you see people with partial autism who run government. It's a little different disorder, all kidding aside. So that was sort of my being. So delusions and hallucinations, fundamental. The affect. Affect is your appearance of how you're feeling. What is your affect? Depressed, cheerful, whatever. It usually can be flat. And I always wondered whether it was part of medication you were getting that does it or not. But it's characteristic of the illness. And that was the part that the early guys who did this made comparisons with it and autism, sort of that distance from people. And I don't know how true that is, but that clinical aspect of the disease is there for sure. Okay. French people. Any French people here?
Don't raise your hand.
Is there French? Are you French back there? Bonjour. I guess I didn't say that very well. Okay. The frogs. Sorry. Why am I talking about French people? Okay. They had not bad medical science in the 50s. Not that they do now, but it was good. And they were developing new anesthesia agents. Okay. And one of a class of them was sedating. And one of the anesthesia and the scientists pulled in a psychiatrist because he thought there were several people in the study who had mental illness. They didn't die. And were all of a sudden getting better on this medications that they were trying, anesthesia related and things like that. And that was the discovery of antipsychotic drug that changed the game, changed the bloody game. And so the first one really that was around was Thorazine. In India, I remember my dad coming back, he was talking when he was a doc and during the war, Second World War, he talked about, he had a British colleague, pardon me with a nice accent, I was going to imitate him badly, but commented that Indian docs would treat schizophrenia with a drug that was called Reserpine, right, which is a legitimate blood pressure drug, but does some of the same things that the other drugs, and is an antipsychotic, not the most effective. But it was really probably the first that was treating the, and that was India, and it was common for many years. And when the French people came on with chlorpromazine, which became thorazine, it moved fast. Okay, and it was recognized, and it moved bloody fast. And it started to empty out the mental hospitals. And the mental hospitals here throughout the United States were packed and overflowing. And it started getting people out of the hospital. That's the good news. The bad news is there was nothing for them outside the hospital. And that exists to this bloody day. When I was doing the research, it was a funny world that we lived in. You only could do things that could be done there that may never be done there again. Who knows what's going to happen to my poor NIH. But we could study people. Everybody was on double-blind medication. Do you ever know what that means? In other words, there were placebos. They'd walk in, I'd do my thing. I was the boss. I had the young doctors look at them, do all that bullshit. And if they were good and want to work with them, they were there. And then they'd start taking 4 pills 3 times a day. They were all identical. And it was much more crude than it exists today. Through codes and so forth, we changed them from placebo to active drug or back to placebo. So I had an unusual experience of spending considerable amount of time with drug-free patients with schizophrenia, which is an extraordinary experience. And if you ever want to think why people looked at the original antipsychotics or the original neuroleptics, as they were called, as wonder drugs, when you saw them on a patient who'd been so sick and get better, it is like a wonder. That's the good news. The bad news is it doesn't get them well enough. And that's the sad part. And the number of antipsychotic drugs or neuroleptics, they used to be calling them the second generation, is numerous. I'm going to talk, before we leave, I'm going to talk about one. Cobenfy, which is, you may have heard of it. It's a new one that just came out. I won't bore you too much with it. Maybe I'll try not. But the drugs are fascinating. Okay. Risperidone, which is an antipsychotic from my hometown company, J&J. Janssen Pharmaceuticals is part of Johnson & Johnson. Paul Janssen invented risperidone. He invented haloperidol. My favorite is he invented low modal, so he didn't have diarrhea. So he was a genius for that. and unfortunately, he invented fentanyl, which is why we hate fentanyl today, is understood. But in the day, fentanyl is an extremely important drug for post-operative pain. It was by far the best It was potent, and too potent to allow you to prescribe it as an outpatient, the way it moved into, and hence the tragedies that we all know. But Dr. Paul did that as well. And that was at Janssen. At one point, risperidone on a yearly basis brought in the United States about $6 to $8 billion a year. Not bad, huh, John? Oh, you're not impressed? Jeez, I was impressed. That's something. Isn't that interesting? More than all Hollywood ticket sales throughout the world. And that was just for that one drug in a larger group of drugs. The use of them is enormous. The ones that came out were real. What's needed is better by a lot. And there are numerous antipsychotic drugs, all of which are similar. Then there was a weird drug. Are you guys, am I talking too druggy? Are you guys okay? Because I can do jokes very quickly. No jokes? Okay. No, that was my wife. I said, don't, no, it was an extraordinary thing for the pharmaceutical industry. Then there was a drug that came around in the 70s. When I was a chief resident, I sent a patient, a nice woman, she was fun, a nice woman who got damn disease. And the old drug can give you a side effect in your motor system called tardive dyskinesia. And there was a drug called clozapine, which was just came out. And they had it at the NIH. I remember sending this patient to the NIH, and I finished my residency in 77. Okay. And I ended up spending decades of my life studying clozapine because it is by far the most effective antipsychotic drug. It's underused. And it's underused because when it was under experimentation, one of its early places of clinical trials was Finland. What's our Finnish, our dear people here who live in Somerset? The Ritva.
Yeah, Deweeses.
Deweese. Anybody remember the Deweeses in their house? Do you remember that? They're Finnish. And her story was...
She's finished.
She's finished. He was finished. But,
California.
yeah, I know. Anyway, but Ritva told me, she talked about Finnish people, Finland. She said that we were odd, Finnish people. And she said, how do you know an outgoing Finn if you meet her? Anybody know? Let's tell you what she told me. He's the only one who's not looking on his shoes. They're a shy group. But they had another problem. When the Finns were given clozapine, they developed agranulocytosis or loss of white cells, and it was dangerous. As a result, to get this drug approved by the FDA was enormously difficult. And they did a very clever thing, people whom I knew, older than a generation-ish older than I, but I always gave them a lot of admiration, is they used the drug on treatment, clozapine, on treatment-resistant patients and compared it to what other drugs would do, and clozapine beat them up, down, and sideways. Because of that unique clinical potency, the FDA was willing to go with the potential problem of agranulocytosis. Only you had to get bloods drawn, which are a pain in the ass, every week for a while, and then bi-weekly and then monthly. The FDA right now, as we're speaking, is doing away with those because it has limited the number of patients on clozapine. If you go to private docs or anybody around here, what percentage of patients are on clozapine? Small percent. In my practice, everybody I could get would go on to clozapine. And no question that it's a better drug. So it's an interesting aspect that antipsychotics work, they just don't work well enough, and clozapine works better than what you have. And I spent a lot of my time trying to figure out what is it about clozapine that makes it better. And that another whole set of stories and a drug that I sort of developed after that, based on that. That was the fun of being at NIH. It was very nice. I'm telling you, let me see if I can make myself clear or speak clearly. I can't do that. Okay. I was in the intramural research program. Remember intramural sports? Remember that? Intramural research program at the NIH is you do your research there and you don't have to apply for grants. Capiche? They review you every 5 years and try to make fun of you whenever they can. 4 years. It's always put off. It's always put off. I never had mine in 4 years. I think they may have wanted to avoid me, but it always turned out it's correct. It's 4 years. It was always 5, and they review you and blah 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 blah. But they give you the creativity to do within reason with what your senior people thought, in the spirit of what they were studying, and that was a very unique thing. When I was there, I ran the ward at the Clinical Center for Schizophrenia, and we had tried to keep it to about 10 inpatients. It was tough because these people would be off meds. If you've never seen a patient off meds with schizophrenia, that is something. So we had to work very closely, nurses very closely with them, and so forth and so on. And then St. Elizabeth's Hospital, had some intramural beds there. My friend Weinberger and his crew worked there. So between what we had at the clinical center and at St. E's, there were probably 30 inpatients at any one time. 25, 30. There are none. Yeah. They don't exist. It is an extraordinary thing that's happened. And in part, I say it, but not correctly, but I'll say it, I'll give a shit. It was the genomic revolution, which I loved like everybody. But was it Mao? Somebody? Mao? Zedong, wasn't it? Yeah. And didn't he make you wear a dunce cap or something? You guys.
During the Cultural Revolution.
Yeah, thank you. I knew I could count on you. And if you were an academic, if you were studying an academic, they put that on you, right? Well, if you were not doing genomics, at one point at the NIH, they put a dunce cap on you and treat you like shit. Capiche? And you know what that's produced for schizophrenia? Bupkis.
Yeah.
Science, sure. It's okay. It's great. But these people think that the goal of their work is to show how important their methods are, and they could give it done without our patients. Now, that's not saying genetics are not important, on and on and on, but that was not the story. This is baffling, the disease, and it's really stuck right now. Now, let me say another comment about psychiatry. And anybody know, is there a neurologist here? No? Thank God. I mean, let's be honest, okay? Enough. We belong to the same board. So when you get board certified in psychiatry, it's the board of psychiatry and neurology, because our principal organs are the same. The squash. However, there was the old saying when we were in medical school, which was internists know a lot, but don't do anything. Surgeons don't know anything, but do a lot. And pathologists know it all, but it's too late. And medicine is based on pathology. Every medicine. Every neurological disease, you can make it there. Correct me, Trev, if I'm off on this way. Every neurological disease you can make a diagnosis in a postmortem specimen, okay? Not one psychiatric disease. So the difference between neurology and psychiatry is we're dealing with diseases that involve behavior, the organ and so forth, similar, a lot of overlap, only you can't diagnose it in postmortem. You can't diagnose this by any physical thing. I grew up during the period of brain imaging coming into play, which was so cool. And I thought it would change the game. Nah, you still can't diagnose it. You see abnormalities, but not diagnostic abnormalities. They're non-specific brain abnormalities. So it's a fascinating thing how close neurology and psychiatry are and how little they have to say to each other. They couldn't think of more different disciplines in terms of the people who are in the field. And Freud, as you know himself, was a neurologist. That was where that started. You know, that was the basis of where they did that. So, guys, are you folks with me? A little more on schizophrenia? A little bored? Not yet?
Dave, I'm gonna give you, because John won't do it, I'm gonna give you a little heads up.
Too much time.
Coming close,
Coming close to too much. And we go to questions?
and then we go to questions.
Okay. People have questions, I hope?
You can, I didn't want to stop you.
No, you should. You should, because I was just beginning. So you got to feel for the illness. I mean, men and women have broadly the same frequency, broadly the same, clinically a little bit different. Okay, two very quick stories, I promise.
That's all right.
Okay, and then I'm going to go on to other things. So when you're at the NIH, occasionally members of Congress would come. And in particular, they didn't come to the National Institute of Mental Health, particularly, to give a shit. But they go to the NCI, the Cancer Institute, blah, 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 blah. And I got this thing on my door one day that Harold Varmus, Nobel laureate, who was the head of the NIH at the time, wanted to see me because there was a senator visiting and he wanted to see some patients. Yeah, he didn't usually come to us, but we would do that for time. And in walks Harold Varmus, the stiffest man in the world, that I can't imagine what he thought of me. You know what I mean? But he comes, and who was he bringing? I'll never forget, it was Ted Kennedy. And Ted wanted to meet some patients with schizophrenia. And there's nobody more appropriately charming. Do you know what I mean? Just nice in that setting. You know, whatever you think, but he was tremendous. And we had a kid, he was 20 maybe, 21, from Massachusetts. So we brought him out, he was an outpatient, he'd gone through all our studies, nice kid, but has the illness in spades, okay? But stable. We brought him in and Teddy wanted to talk to him. And there's Varmus sitting there shaking. Shaking, literally shaking. And Ted's talking to him, and the nurse gave us a little summary of where he's at, and she very nicely, appropriately said that he's doing very well, and he just got a job, and he lives with his sister, and everybody's happy. And then Teddy says to him, "You just got a job? I think that's terrific. Does your sister, is she proud of you?" And he suddenly got this paranoid look. I thought Varmus was going to fall off his bloody chair. He's a skinny guy anyhow. And he says it like this, paranoid. "I don't tell my sister everything." I thought the room was going to fall. Ted, out of pure innate specialist, looked at the kid and said, "You know, I have sisters too, and I don't tell them everything." How was that? Pretty good? And the kids sort of, dropped that and it all worked fine. But Teddy was there and wanted to learn more about that illness. And that you can put that in your own mind as to why he was so interested. And he's always been good to us. So I'm going to move along to one thing and then we're going to open it up. Is that okay? If you pay attention to the newspapers and stuff, you'll hear that there was a new drug that came out. And now there have been a fair number of new drugs for schizophrenia, but they're the same as the old ones. And each pharmaceutical company has contributed to that. This one was different. We'll have to do another session. I'm going to teach about dopamine. Oh man, it's far out. Dopamine. Okay. The antipsychotic drugs, the traditional ones, and even clozapine, bind to receptors, dopamine receptors. And in the beginning, we thought just plain block them. I made some things in my career. I had a good paper in Science showing that after you start, that the dopamine system continues to quiet down, and we could demonstrate it. So it's not just blockade, but an adaptation to that whole story. And that was a big part of things. Well, this new drug is not dopamine. And it's the old Einstein, wasn't there? Einstein? Did he play ball? No, Einstein, right? Scientist. He was the guy who said, I just want to see if you were awake there. He was the one who said God is subtle but not malicious. And I'll tell you, dopamine has nothing to do with schizophrenia, that's bloody malicious. That's my view. But here's this drug that's an antipsychotic. And it's been in the news the last 6 months. And it works with cholinergic mechanisms, acetylcholine, which is a system that goes to your non-voluntary movements, controls heart rate, all sorts of things, and in your brain. And they were giving antagonists to 2 versions of the acetylcholine receptors, and patients started getting better. That was not, I can't say it was not predicted because it's always intimate, but much better than anybody thought. What it appears, which made me happy in a strange sort of way, is it does it interacting from acetylcholine to the cortex, what it hits, and it interacts with subcortical dopamine, which gives you the psychosis. And it quiets and modulates subcortical dopamine. So the antipsychotics block the receptor in a big, and they cause side effects and so forth. This sort of smoothly quiets it down. And I'm talking to Bristol Myers now, who owns the drug. 30 years ago, literally 30 years ago, I went to Eli Lilly. They asked me to look at that drug. 30 years. And cholinergic symptoms have side effects, which are very unpleasant. Our antipsychotics have bad side effects. Cholinergic ones, GI, nausea, all sorts of issues. So Lilly dropped it. And the guy who was I worked very closely with the United and then went on to Lilly and then his own company. That's when I was a Schmendrick. I stayed here in Somerset, He bought it. He bought the drug. And they added another drug to it, which would block the side effects. And they launched it. And the drug is called Cobenfy, Cobenfy. And it's just look it up. It's become the shit. And how good it is, I was speaking to the Bristol Myers people. I have real questions about how good it is and ways to find out. So I was excited to have anything new. In my old days, I would have loved to have it. And I was trying to start a clinic here with my dog. It just didn't work out well. So look for that drug, and it's been a big boost to us all. Now, I know I can't talk more, right? Is that what you said, Kat?
No questions, I'm sure.
People questions or Jewish joke?
No.
She's not Jewish. No, that's right. You understand? We go through this every time I get a good one.
So the question.
Okay, John's saving me.
Thank you, John.
Hi.
Hey, so I kind of was casting back in my mind about, I think I read somewhere that the other countries have had more success in treating and curing schizophrenia. And I'm also thinking, didn't Kurt Vonnegut's son
Yes.
get cured from some dietary thing?
No, he never got cured.
Or
That's fantasy. And it's a remarkable thing about it is how similar it is all over the world. Now the Chinese they don't care about rules as much, but it's an interesting comment in typical fashion. I thought you were going to ask me about chickens. I was sure I was going to get a chicken question. But let me respond to that. I remember there was a guy I was a resident with, who was younger than I was, and he was American Chinese, Yale College, then he was, a nice kid, smart. And he went on a fellowship to China when it just, the beginning, right before it opened, okay? And he came back and said how bizarre it was. How just just everything, except for one thing. When he walked in the mental hospital, he felt like he was at home. And we seen the patients, he felt like he was at home. And some years later, after I had my unit, the chief psychiatrist from China came and visited my unit. And she was odd. I can't exactly recall, I connected with her. But when we went over to talk to a patient, she knew the patient. She knew exactly what she was looking at instantly. And what's so fascinating is how similar it is across cultures. It really is an extraordinary thing. And the Chinese, I don't think there's nobody who does it better. But there are places that don't demand what we do with people. And our society is not easy, whether it's working, whether it's trying to achieve. Many patients with schizophrenia, you do not have to be very bright to have the illness, but many people who have it are, and they would have a career waiting for it's just tragedy after tragedy. And China has a little different game that way. But it was very interesting when she came over. Now in Russia, they do things a little different. If you protested, here we go. Okay, your talk was terrific. I'm the schlepper, your talk was terrific. Do you know what? They had separate schizophrenia. You know that? And I did this World Health Organization coordinator. I was a coordinator. It was a big promotion for us. And the guy I had to deal with was the head psychiatrist in Russia. And he looked at me every time I saw him, like, boy, I could get my gold teeth into you. God, he wanted my ass. Okay, Russia. They had a unique name for a type of schizophrenia. Slow schizophrenia. And slow schizophrenia was if you protested, you were put in the hospital and given antipsychotic medicines, which were very unpleasant. And they called that slow schizophrenia. How about that? And it was a big thing in Russia. And Russian shrinks were not dumb. There's a long history of psychology and so forth and so on. But I'll never forget that. And it was sad and creepy. So anyhow.
Another question?
Yeah, another question. Thank you.
50 years ago, one of my close friends, from the group of friends,
Yeah,
turned schizophrenic, and we all abandoned him
yeah,
because he was just too hard to deal with.
yeah.
That couldn't have helped. Is that typical? Or?
Yes. So my friend Sandy, the headmaster's son, who got sick after high school, nobody would. They'd have him at parties, but you couldn't deal with him, and he was very paranoid, and it's a creepy feeling. No, it's the saddest, bloody thing in the world.
You know.
I dealt with him. I did. I always liked him as a kid. We were friendly, but yeah, no one wanted to do business with them, and people pulled me aside and said, "What happened to Sandy?" Because he was just so different. I told you, all the schmucky kids were rich, and me and Sandy were poor.
So I shouldn't feel guilty 50 years later.
No, it's the common. I'm teasing, but I'm not. It's the common ground. It's very hard to maintain a friendship with somebody who's ill like that. It's hard because the behaviors. Yeah, because the behaviors that come are interruptive and so forth and so on. Okay. Another question. Yeah.
Yeah, you said it's very similar across cultures. I mean, is it very similar across patients? Do all patients have the same symptoms, same disease, or is it variation?
It's remarkably, yes, there are versions that I have more of this than that, but there's a core aspect, and they 100% have. You can't get the diagnosis without it, but it's remarkable just how it's there. You see it as an illness. It really is something to see, and the number of times I've seen it. I am, and I'm not going to go back to old things like the Bible. I'm not going to do that. Okay, no matter how much you beg me. Yeah.
So if this chemical change happens around 18 and 19, is there any way to anticipate screening?
That was what we used to work on, and very unsuccessfully. The best version is if they have a sibling who has the illness, then their risk goes up, but not enormously. If they're a twin, it goes up more. So no, it's not easy.
Yeah, it's in us.
Oh, I was a second-year resident, and I real quick, I promise, admitted this guy. He was old. He was probably 35 back then. I thought that was old, and he had the illness. Big, nice-looking guy, and I hospitalized him. Got it done. And then the next day, I saw his parents come in, and I spoke to his parents, and it was a little different. This gets personal for me. A little different than other parents I'd spoken to with a sibling with the illness. I can't quite explain. And they didn't quite connect with the kid. They were very caring about him. They were as sweet as can be. It was distant. The kid was adopted. I have 2 adopted kids. And temperament is a very inherited thing. And my kids, unfortunately for them, have me to deal with. And I'll shut up. But my older daughter, Bess, who looks British, she said to me in high school, "Dad, I think I'm more British than Yiddish." She's very proper. And we were seeing, I'd go to, Kathy was a professor at GW, I'd go to all the basketball games. She'd sit next to me. And what did I do with the games? Everything hey, no, ref, what are you crazy? That's bullshit. Dad, be quiet. So temperament is inherited. It's an interesting aspect to it. So I don't know if that quite answers the question. Yeah.
I'm curious what you
Yes.
say about the schizophrenia is sort of similar in terms of occurrence and symptoms across culture. Is that distinctly different from other types of mental illness?
Good point. Yeah. Yes.
So
Uh,
like depression or.
Depression is a very variable thing. In Japan, they never highlighted depression. It's cultural things against it. Does it exist in other places? Absolutely. But not quite like this.
Personality disorders?
Yeah,
Vary?
yeah, but I think it varies with the culture and so forth and so on. You're absolutely right. This is a little unusual. I mean, it's so, that's like what the kid said when he went to the hospital. It just cuts across culture. You just see him and you know the illness, you know who you're talking to. It irritates me. It blows my mind. Yeah.
So I always hear that psychedelic drugs can trigger schizophrenia. Now, I want to know, does that imply that there's a predisposition to schizophrenia, but then there's some sort of environmental event that actually causes it to?
People, we've all wondered about it. There was a much higher end, and I'm gonna come back to psychedelics. That was on my list. I was gonna sell some. It's not easy making a living as a doctor. I won't tell that joke. Okay. Psychedelics, not good for patients with schizophrenia. Now, the first psychedelic drug was LSD. And that was, let me see how to tell you, it was my day. Not just that we all used it, that was our thing, but they discovered it was serotonin related. That came out during my day. So I remember at Yale, there was a big push of seeing psychosis related to serotonin because of LSD. And while serotonin, no question, has effect on behavior and so forth, I'm not sure that's directly to the illness. If you give LSD or psychedelic drugs to a patient with schizophrenia, it's dangerous. I don't mean each minute, but it's just bad. It's just bad to be done. Marijuana, probably the same. You know, I've never known ever did those experiments. So the psychedelics, which thank you for bringing up, which is the new thing in psychiatry, correct? Capiche? Huh? You know what I'm saying? Is a fascinating thing and is so against what Trey and I grew up with in our generations. And I have very big concern about it. One of the drugs that people use is a drug called ketamine. I did a lot of work with ketamine. I loved ketamine. I mean, okay, once or twice. But ketamine is a very odd drug. And it's a dissociated anesthesia. It's an anesthetic agent. And it was famous from Vietnam. And that's when it came in. That's when it was approved. And what it was in Vietnam, you talk to medics in Vietnam. So this poor soldier you would get his goddamn leg blown. I mean, what went on, we can only imagine. And then my job as the medic was to stop the bleeding if I could and get him to the helicopter to get him to a hospital. Okay? These guys have a leg blown off and they're going crazy. Ow, I dare you! Carrying on. And they couldn't deal with him. Ketamine came along, doesn't suppress the respiratory system, which is safe. And they used ketamine, they would say put him in a K-hole, and they would give him ketamine, sort of this dissociative anesthetic, and get him to the hospital, to get him to the helicopters in the hospital. It is a psychedelic drug. It is a behaviorally active drug. So in my early years, jumping back to the Yale years, I was interested in any drug that changed behavior. Any drug that was behaviorally active, I was interested into why, how, and so forth. And the psychedelics were all in that pack. Now there's a push now to use psychedelics as therapeutic agents. Ketamine is out there, you can use it, but it's an odd story. I don't know if any lawyers here who know about the FDA. If a drug is approved by the Food and Drug Administration, a doctor can use it any way he or she wants. So if I could take Prozac and use it for skiing, I can do it if I want, okay? Once it's approved. And ketamine was approved as an anesthetic agent, right? Which left it open to be used. And it's an odd drug. My feeling is I wouldn't touch it in a million years, certainly if you're not well. I've been unimpressed with what I have seen. And I spent a lot of years studying it in normal people and in patients with schizophrenia. And so I'm not a big pusher of it. NMDA, ecstasy, MDMA, ecstasy was turned down by the advisory committee to the FDA. I was on the Psychiatry Advisory Committee for 4 years, where I saw every drug that was coming through. It was an interesting experience. And they turned down that drug before they never even review it beyond. And that is a huge cult market. It is a big deal. And people who want to develop it say how stuffy everybody is and blah, 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 blah. So keep your eye on it. And it's while it's changing and I'm getting old, but it is a fascinating thing. And those psychedelic drugs were the first drugs that gave us hints into what was going on in the brain with serotonin. The other hint, which brought us to dopamine, was amphetamines or cocaine used a lot and chronically can produce psychosis, and they released dopamine. And that sort of fed into the dopamine hypothesis and the discoveries of the 60s and the 70s when that became big news. But interesting about the psychedelics, it's on everybody's toes right now. There's something. Yeah.
What about marijuana? We talked about this before,
Yeah.
but now did you see this Canadian study that's just come out?
That makes you sick.
Well,
That one?
yeah, the marijuana is a trigger.
Yeah,
for
that was what I grew
people
up.
who've
Here's
already
what's
got the
weird.
gene.
Here's what's weird. That's what I grew up with. I grew up with that as a resident when marijuana first came out. And the very smart professor, Tom Detry, he insisted. He insisted. Do not do it. Now, does it cause schizophrenia? No. But can it bring out what you?
It triggers rather.
No question about it. And if you want to go to the other psychedelics, don't do it with these folks. Okay. And so, I grew up more than you guys grew up in that generation. But they're not great. But there is a huge cult. A guy named Peter Thiel, Elon Musk.
Yeah.
Who do you think is doing what does he call it? Low dosing? What do they call that? Microdosing. That's when Trump got up and danced. That's what I thought happened. I truly thought that Elon went up to him and gave him some microdosing. Because
Wow.
you know what? I love having journalists around me. What do you think?
That's grateful.
Yeah, when he was doing that dancing, are you kidding me? That wasn't even his personality, right? Did you think the same?
I don't think.
John and I go to practice together. All he has to do is speak with that accent. He's the pro in Dover. The bro from Dover. Yeah, other question. Hey, Johnny.
You talked about these patients and you talked about one drug that you thought was really good that you tried to give them all the time. So in just layman's terms, how did they act normally when they were on these drugs? Was it okay? Did they
got very much better. Would I say since that there's no trace of the illness? I'm not sure I'd say that, but some individuals, yes. In some individuals, yes.
They could live, they could.
Yeah.
Yeah, and then how about Cobenfy? When
We
is
don't
it
know
coming
yet.
out?
We don't know
When
yet.
is Bristol Myers Squibb putting it out, and when? And how are they gonna act differently?
Well, I'm going to be speaking to the head at BMS because I'm very shy. But I thought I'd suck it up and tell him my advice, asshole. Okay. Bear with me on this, and if it's too much of a detailed story, I apologize. The way they could get clozapine, remember clozapine because it had the side effects of the blood, was they did a very complicated super trial in treatment-resistant people. Capiche? And so that made it a drug that other things didn't work for and gave it a raison d'etre to try this drug that could hurt your blood count. You got it? And that's what clozapine is, the only drug that bears the indication for treatment-resistant schizophrenia. Now, because of the way it works on dopamine, I'd like to see it added to a traditional antipsychotic. I'd like to see it in treatment-resistant people. I have a lot of questions about that drug, Cobenfy. I have a lot of questions about it. It'd be very helpful. Now, industry, if they have it on the market, the last thing they want is you to fool with it. Now, maybe they want other people to fool with it, just not me. That could well be personal. But this is bringing in huge amounts of money. And industry is the pharmaceutical industry is very peculiar that way. But I'm be speaking today.
You're saying you don't think it's quite there. You think it could be better, but you think it's going to be.
I don't know yet. I'm going to be speaking to the BMS people next week. And I don't believe they're doing the studies. You got to, man. We need it. So BMS is Bristol Myers Squibb. And I want to see it in real treatment-resistant people, comparing it to other all the stuff I used to do at NIH when NIH used to do things.
But the advantage is it's not going to have the side effects.
No, it won't have these side effects. If you can bump you to treatment resistance without these side effects, holy smoke! You with me? So that would be very interesting, and it's been interesting. It's been a boost for the field at a time where the field doesn't almost exist anymore. Basic science exists, but what I grew up doing and what we all grew up doing is barely alive in today. And right now, with what's going on with the things you know as well as I do, it's going to be a very tough period of time for doing these studies.
But the problem with clozapine is a pill they have to take. So if they don't want to take pills, it won't work.
I'm sorry?
You have to take, with clozapine, it's a pill, so
Yes,
they have to be compliant.
So is Cobenfy.
Yeah, no, as opposed to.
Well, the other thing that we use to treat our folks with are long-acting injections.
Yeah.
And they're not of clozapine, but they are, but I remember when I first saw one, I was a resident and they were using Prolixin and this guy who was attending was giving a shot. And they now can last longer, but traditionally they were every 30 days, now they're every 3 months and more. And it's life-saving. One of the problems in working with folks is they want to go off the medicine. Cobenfy is more comfortable than any other medicine. I think people will stick on it better, but the discontinuation is enormous. Because they're not comfortable. So what they used to say about antipsychotic drugs, it's the only class of drugs that you can't give away in prison. Okay? No prison, they know enough. They don't want that goddamn thing around them. Yeah.
So what happens when people start to fail? Is it because they get resistant to the drug, or does the disease progress?
The disease does progress. It is a volitional treatment. Now, if you have an injection, when it works well and you have a good relationship, I know I hate the drug too, but I'm going to take care of it. You don't have to worry about it. You're coming in here every 30 days. I'm giving you a shot. Shabbat shalom. You know what I mean? It gets you out of trouble. But patients don't like it. Number two.
David, we've got to go.
Oh, we got to go. I'm so
Don't
sorry.
take it personally.
Yeah, no, I didn't. So is she leaving you two or just me? Just me, okay. I want to, how big a deal this was going to be. People with the illness, and this is an awkward thing to say, I'll say it in sort of a functional way, they sometimes want to get ill. And I can't use the term want in its traditional word, but they do. And one of it, they have a hard life. And they're constantly hoping that somebody's thoughts are not being put in their mind. They're hoping that, they're exhausted. And then when you go off the medicine, the early part of the psychosis, I'm not sure is rewarding, but it can be entertaining if, maybe not even entertaining, but you feel a little more alive. Okay. And you don't give a shit that people don't pay attention to. And then you're sick. And then you try and get into a hospital right now, which is so hard to do, and so forth. But so discontinuation is a serious problem. It's very difficult. Yeah.
Last question, I think.
Yep. Sorry.
You want to add?
Yep. Did you say 1% of the population
1%.
has this
That's
disease?
disease. Yeah.
What about 50 years ago or 100 years ago? Any idea?
You're so smart. It hasn't changed in my lifetime, and I've been a doc for 50. Okay. But it's a very interesting question. I got another problem with it. You ready for this one? Why is it not going down? Do you know what the reproductive level of these folks is? Are very low. It's very uncommon. Why is this not decreasing? These are things I think about all the time. And the beauty about
But it is genetic.
it's something, it's something. Okay, you with me? And one of the fun about being in the NIH, being there, which you could talk about these things, not just to waste time, but to tickle your own brain and your buddy's brain and the dumb ones from Harvard and shit like that. And they're dumb, I'm telling you. But all kidding aside, they're baffling things like this. How is it possible? The fertility rate of patients with schizophrenia is bupkis. That means bullshit. Yeah. Yeah, no, it's a fair question. How about other questions? Yes.
There's an institute at Hopkins related to psycho.
Yes.
Are you familiar with what they're doing?
Which one, the Lieber Institute or the?
By Weinberger.
Yeah, Danny and I. This guy.
Danny.
Yeah.
Do you know Danny?
Yeah.
Weinberger and I grew up together,
Oh.
and at one point we were very close. I have my issues with Weinberger, but you know what I mean. I'm a Jersey guy. That's what we do. You know what I'm saying?
He grew up in New York.
Yeah, right. They bothered me what they did, and they've largely done basic research that is not quite their calling, and they should have used their money to take these people in and work with them, and they didn't. They wanted to get employed. They wanted Nobel Prizes on their back. Okay, and Danny was a good doc and very knowledgeable. So he and I started the same day, and he ran the schizophrenia research program at St. Elizabeth's, and I ran it in the clinical center. So we were very close, not a little close. We were very close. And I'm not going to say anything more, but I wouldn't have done it that way. But then again, I would have done it on a golf course or some shit like that. But all kidding aside, but Danny is very smart, and I said my spiel. Anybody else? I'll be nice, I promise. Yeah.
I'm sorry, really, can you just talk, I know you're not a public health person, but given the number of people on the streets, given the unmet needs of the population with the disease, like, what is the humane and smart, scalable strategy for our society?
It's really an extraordinary question. The original idea was putting people in the hospital. Well, that's not probably as necessary as it was, although it's more than people think. Yeah, they're all in jails. Who said that, Kathy? I told her everything. The largest, what the people say, what the rap is, the largest mental hospital in the United States is Rikers County and LA County Jail and Rikers Jail, New York, have more schizophrenic patients in their facility than anywhere else in the country. So they're not in mental hospitals. My God, in the insurance systems, no one wants to look at them. And the old state hospitals sort of exist, but barely. So it's a very sad thing. It breaks my heart walking down the street. The other side of it is how dangerous it is. And the number of patients with this disease, understand, who hurt people and kill people is a real issue. And I worry about it. I do it at a very personal level and so forth and so on.
But the largest percentage of them are not violent.
Yeah, the largest percent are not violent.
But those, yeah.
But Kathy's trying to make me politically correct.
But they treat them and they release them. I mean, it seems like they come to San Francisco General Hospital, they get treated, they get stabilized, and then they're released back onto the street.
Actually, you're telling a good story. That's a good story, if they get that far, yes.
Okay, but like if they're treated at the VA, they have a network of a little bit of being.
The VA has done nicely. I like the VA.
So the follow-up would be, let's look at how we could,
Just about money. All it is money.
well,
You think that's going to be good today? I mean, it's an issue.
not unless they're billionaires.
Yeah, right. Like Mr. Musk, maybe he can do it for me. I'm after him. I'd like some things from him. But anyhow, yeah.
I want to ask you a lot about schizophrenia. I thought you would kind of talk about mental illness.
Yes, I'd be glad to.
Okay. But what I have observed having young grandchildren about the how do you call it, deficient
ADHD.
Yeah, so when my kids grew up, which are in the 40s, you didn't have it. Now it's all over.
It's more it's been there. It's been there.
Okay, but now
Wasn't diagnosed that.
Well, I'll tell you what's weird about that. When I was a resident, let me say something. The way you would diagnose it, people would say this, is you'd give that child, that kid, you give them amphetamines.
what?
Amphetamines, stimulants, Ritalin.
Yeah.
And if they got better on Ritalin, then you made the diagnosis. And that's no way to make a diagnosis, but that was almost what you had to do. And it is extraordinary. If you give that 16-year-old or 50, whatever he is, 14-year-old kids.
Talking about 6-year-olds.
Well, that's young, and then that moves into a separate category. That's a separate, and you're concerned about that, not in a traditional ADHD way, but you wonder if there's other things going on. And you're not going to know until over time. You're not going to know over time.
Is it connected with dyslexia?
Yes, and dyslexia and learning disabilities are very difficult. And I think so much of illness in young people are kids who grew up with learning disabilities and not recognized.
Yeah.
And it's a very sad thing in these kids. And ADD goes with it. Fact of the matter is, ADD people do well on stimulants. And in terms of other things, some are very, very successful, but others not. And it's very damaging. And it's closer to a brain damage than an inherited disease, the ADHD, from whether it's delivery or from other unknown causes. But stimulants still, Ritalin, Dexedrine, they still do very well to calm that behavior down, whereas normally you give it to a kid, it buzzes them up. So it's one of those things, it's typical of psychiatry. It's the only place in the world where you give a drug, it does opposite to what it does to everybody else. And that's what we had to deal with. It was hard, but that's correct.
So you feel it's more.
Well, there's another thing, is in my day, psychological testing to determine learning disabilities was rarely done when I was young.
And think about when you were young.
Yeah.
Did they didn't have dyslexia, anything?
No, they didn't do
They
the
didn't
learning
test.
disabilities the way they do now.
They didn't test.
And
They
it
didn't
was,
test.
and now the good testing is hugely important. And my heart goes out, my heart goes out everywhere, but to certain learning disabled kids, it breaks my heart. And because they could be extremely bright, but they're sitting there, and the guy next to him who's not very smart, he gets it right, and they're out in left field somewhere. And it's a morale depleting disorder. And they almost say, "What's your name?" "My name is Be Quiet," because that's what everybody says to them. And so it's a tough disorder. We can work with it now. And learning disabilities themselves, or if people have kids or relatives with learning disabilities, it's very important to recognize it and to help them. It'll make a huge difference. And you can be very bright with a learning disability, which is so tough on these kids. The learning disability, they're bright, but they can't do as well as schmuck face over here. Are you with me? Am I talking bad? I'm just trying to give you a flavor.
Jamie,
Yes, I'll be quiet.
no, before this turns into a general session of counseling, I want to thank you.
Thank you for having me.